So thank you so much for having me. My name's Professor Nora Colton. I'm a professor of leadership and management at UCL, and I'm the founder of the Global Business School for Health. And I set the school up in 2021, and we took our first class in 2022. We're now on our second cohort, and the school is growing at an exponential rate. So we had over 2,000 applicants for 4 postgraduate programs when we started. Last year we had about 3,400. We continued at about that rate this year, and we've grown the school. It's about 530 postgraduates now on a number of different programs. So what I want to do today is just talk to you a little bit about the school, but why a business school for health, and be a little provocative. So many of you may or may not know very much about UCL. Of course, it's rate very high, but more importantly for me, UCL has a history of being a disruptor. It's almost coming on to its 200th birthday, and in those 200 years, it has achieved numerous milestones, particularly around accessing very diverse students, focusing on real world problems, not just on theory, and of course theory is very important, but trying to really address many of the issues that we face today. And of course, aging is a very important part of that. UCL has an Institute for Aging. As many of you will know, just a few weeks ago, UCL had a breakthrough in Parkinson's diagnosis. So much of what UCL does is across the brain sciences is probably the most significant area. The medical sciences, population health sciences, and that's where the Global Business School for Health sits, and then of course life sciences. So it's within that tradition then that we set up the Global Business School for Health. The idea was that health and healthcare are often not really dealt with very well in business schools, and that we have been taking a health service approach for a long time in terms of how we manage and think about health, both public health and hospitals. And we need a different kind of lens. The health sector itself is changing significantly, as we know. And so the idea was to create a school that would offer a kind of an alternative approach to thinking about health and healthcare management and leadership, and really challenge that status quo that many of us have probably been matriculated in. So the school is really focused on real world problems and challenges, and of course aging is one of those. And the idea is to bring people who already have a background, maybe they've studied science in a particular area. We have a lot of students who have pharma backgrounds, biotech backgrounds, other life science backgrounds, but we have numerous clinicians. But we also take business students. We take students with economics backgrounds and social science backgrounds. And the idea was to bring them together to focus not on disciplinary silos, but to focus on these wicked problems, these challenges that we hear a lot about today, to think about how to drive forward solutions. The other premise, and again, you may or may not agree, but bridging that public-private partnership divide. No criticism of public health, but public health in too many countries is almost like a luxury. So we spend a lot of time focusing on public health, but we don't have the finances to adequately fund public health. And so subsequently, you get a vast majority of the population searching and finding their health care in the private sector. And often in some countries, especially low-income countries, ironically, the public health sector will be regulated and the private sector will not be regulated. And so they're going into a very risky kind of place in which to sort out their health needs. So we put a lot of focus on public-private partnerships, and subsequently we developed relationships around that. But more importantly is this idea of the new health economy, particularly driven since COVID. So you can imagine I was busy thinking about what this school would look like, the vision during COVID. And, the health sector, if we think about it, for about 100 years, we had a very stagnant sector. And the last 30 years, I would say we've had a declining sector. Not because we haven't had overwhelming demand. How do I know that a sector is declining? Well, when all the language is about cost savings and efficiencies, okay? So one thing that COVID has done is it helped to break us out of that cycle and move us back over into the beginning of a kind of a life cycle for an industry with startups and the funding in digital health and the acceleration of many things that were out there. Of course, disruption doesn't happen in a moment. It was there. It was just not being crystallized or actually used within our healthcare system. Having said that, though, we've seen some things go back. I have a colleague who's done a study looking at care homes in the United States, seeing which care homes, of course, during the COVID, during the pandemic, they all had to switch to telemedicine, and in many cases, we know that's very good for patients, putting them into vehicles, driving them to hospitals for various tests. So if we can leave them in one place and care for them. What she's found, though, is that those care homes that embraced it, they embedded it, they hired the technicians, they purchased adequate and appropriate equipment and sourced it correctly, they've continued to do that. The ones that did it much more as an emergency moment have gone back to the ways it were. So we have a lot of work to do, but there are many things, like I said, the use of data analytics, we got much better during COVID. Of course, we all could give ourselves a test at home and mail it off to various places. But we also saw some significant problems around supply chain, and then of course what we heard about earlier, the reprioritization of social determinants of health. So it was people who were older, particularly those who were more frail or had other comorbidities, and of course even young people who were not having adequate health care. So this new health system is not only about thinking about care delivery and vaccines and diagnostics, and of course finance and payments, and then of course wellness and platforms, but it's also about thinking about now who are the new stakeholders. And I think that's again where having a business school for health comes into play. So we can see so much, and I just in the brief time I've been here this afternoon, hearing some of the innovations, some of the research. But it takes leadership, it takes managers, it takes people who can have that vision to bring it into the system. And we see that we're not only aging is an incredibly important topic, because it's not just here in the England and Wales, it's worldwide. I have been to China a few times in the last several months, and I can assure you it's uppermost on the minds of Chinese, because they have had a one-child policy. So as their pyramids flips, they have a real crisis at hand. And so using medical devices and technology is going to be integral for them to address that problem. So what do we need then in our health systems to take care of all of us? We need access, okay, and again, it's appropriate levels of access. One of the biggest criticism, and I'll get on a little more, is around primary care. We talk a lot about needing primary care, Even in this country, we have numerous people who have chronic illness who still go to tertiary care facilities. They could probably be treated in a better primary care system. We have people who go to hospital in this country, and they spend way too much time in the hospital. We often talk about the emergency room, and again, it's teaching health systems thinking, right? And we talk about the fact, I think it was when Jeremy Hunt was the health minister, but they made the 4-hour rule. You could only have someone in the emergency room for 4 hours. The problem does not lie in the emergency room. It's the problem lies, it's systemic. Okay, so the person in the emergency room can't get you up into a bed. They can't get you up into a bed because the rate and the number of days that someone spends in a hospital in this country is 5 times what our European partners do. Why? Because there's no social care. They can't get them out of the bed. There's no one for them to go home to. There's no rehabilitation facilities for them to go to. So these are all system problems, and they're integral to what we do at the Global Business School for Health. So it's not just about access, it's about quality of care. And then, of course, the other thing we see, and we don't see it just here, is the wait list. It's the timely care. And what do we, what do managers and leaders determine as being what I would call critical care or elective surgery? Well, if I need hip surgery or knee surgery, that's not elective, okay? But it's often deemed that way, and people wait way too long. And if you're older, that means that you become more frail, you lose body mass. So once you finally get that surgery, you're not able to recover that you should. And of course, if you're younger, you're often out of the labor force. And sometimes when you've been out of the labor force for a significant amount of time, you never get back in. And so then that really exacerbates those social determinants of health. So it's all here in the system. And then, of course, we want care systems that don't create catastrophic financial burdens. So I'm not advocating a system like they have in the U.S. That doesn't serve everyone. So the challenges are big. And then, we can see also here that we've got a big problem here when we talk about aging, because we're too addicted to our hospitals, okay? To do much of what I heard earlier, it requires a real mind shift, but it also requires finance, okay? It takes leaders and managers and politicians and policymakers who get it. And right now we do a lot of talk about it, but we're not quite there. And you can see here, we've got way too many of our elderly people going to hospital. We got them medication next, and look how small primary visits are and out of patients visits. So this is a problem because these individuals will often, and in an election, as we all know, they will vote for hospitals. And hospitals are very powerful. They're not just powerful in this country. And we're also exporting it to middle and low income countries, the same mold. But yet we need to be really moving into a different kind of health system, because it's costing us a tremendous amount of money. And you can see here, we're spending, if you look, yellow is the proportion of the population, and the purple is the proportion of spending. And we spend a lot on people at the end of their lives because they have not, we have not reached the point that we're extending the quality of life. We're just extending life, okay? And then we're exasperating it by not having our health system structured and placed as it should be. So we need to shift our health systems. It's not just in this country, it's globally. And we need different kind of thinking. We need, again, people need to be able to stay at home. They need to be able to use artificial intelligence. They need to have wearables, and the reality is we can't send everyone to care homes. So at some point, there's going to be a tipping point where some people will get to stay at home and they will have devices that will keep them better. And then we'll have some people who are just going to have to stay home, because we cannot keep the model of care going that we have given the numbers. And it also gets to workforce. I hear people talk all the time, we need more doctors, we need more nurses. Actually, we need different pathways. We need ways in which we bring technology and use data more efficiently, as we've heard colleagues talk about today. So that is really the heart of the Global Business School for Health. We're an interdisciplinary department. We have people that reflect our students. So we have people who are social scientists, we have psychologists, we have data scientists, we have AI experts, we have a lot of people with business backgrounds, people like myself. And we use lots of different ways that we work with our students. So Anthony was talking about simulations. We use simulations. We use case studies. We do experiential learning, where students get opportunities to travel to different parts of the world to see other health systems. So the focus is really on this new health economy. What do we need for the future, and how do we need to train the next generation? So we have a program on biotech and pharmaceutical management. We don't teach students any science. We teach them about the business and management of biotech and pharmaceutical management. We've got digital health and entrepreneurship, very much focused on startups and ideas. And all the students, I heard mentioning these projects. The idea is to build a entrepreneurial mindset into the students. So, because a lot of times health professionals have been matriculated into a culture of regulations, a culture of hierarchies, a culture where you're not encouraged to be innovative. You're actually discouraged to take risks. So getting these health professionals to think differently then takes a kind of bold curriculum. And all of this, just to tell you quickly, we designed the portfolio. We used AI. We looked at an algorithm that scanned all the job ads in various key countries. And then we could see what were the traits that employers were looking for, what were the roles that they were looking for, what were the things that looked innovative and change. And then we did a number of surveys with not just potential students, but also with employers. So we really landed on 3 research areas. We have health systems and policy. And again, it has a real focus on primary healthcare, and looking at things like urbanization, commercialization. Of course, climate change is also very important. And then this piece around public-private healthcare. Then we have health management and innovation. And we've recruited experts across the world. We're a very, very diverse group of individuals, both in terms of our disciplines and our backgrounds. So we have health management and innovation. Again, that's where we have the technology, the AI, the data-driven approaches, but again, really focusing on patients and private-public partnerships. And then last but not least, health finance and operations, where we have a team looking at different models of healthcare and analyzing the different drivers of health spending. So why do we believe then that business and health make good sense for upskilling professionals? And by the way, we do a lot of work, not just our degree students. We're moving quite rapidly into doing short courses, executive education, working with different countries and organizations, because we need those leaders. They've got the insights. They can look across, not just and think about their own country, but think about others, have that business acumen. At the end of the day, I work with an organization on a program that works with NHS leaders. Trusts don't get in trouble because of being too ambitious. They get in trouble because they can't balance their books, their finances. Okay, and this is part of the reality. And so also bridging that gap between clinical and management, non-clinical, and getting that understanding. I meet sometimes clinicians, wonderful, great ideas. They have no idea how to put together a business plan, and they have no idea, about the cost structure. Then I meet managers who are working in hospitals. They do not understand what is the day-to-day business. So we need to really bridge that gap as well. We need people in the health sector who have more like zigzag careers, I call them, where people can move from one thing to the other, so they stay in longer. We have a problem with particularly nurses, retiring early. I meet nurses in all sorts of places outside of the healthcare system. Why? Because they felt that there was a glass ceiling. They couldn't get any further up. So giving them those transferable skills, giving them career paths, widening their ability, and then of course this problem solving and entrepreneurial skills. So just lastly, it's about really taking world leading interdisciplinary academics and having them cover much wider areas of expertise, sometimes areas that they might not feel comfortable with, but they've got other experts that they can tap into to really create subject areas that are much more focused on the health system of tomorrow rather than the silos of today. Thank you.
Thank you very much, Nora. Do we have any questions for her? Yes, Nathan.
Hi, Nagel. Tremendous presentation. Thank you for that. I work with healthcare leaders around the world. One of the regions, which is the Middle East, and we find the approach to leadership in different regions varies. So what works in the West does not necessarily work in the Middle East. How are you approaching that within the school in terms of doing the interdisciplinary elements of culture and geography?
Yeah, so that's a really good question. And actually, I do a lot of work in the Middle East, and we're very engaged in the Middle East. I think I wouldn't over-egg the differences. I think some of them are more about history than actually good practice. And I think there's a real appetite in different parts of the world. So rather than, of course, I would say it's not so much, it's how health systems have evolved, and there is always, of course, a cultural context. I think to health systems, what is that culture? It gets back to our values. What do we value in the society? And that doesn't always run clear through all societies. And there are, if I go to China, for example, they put a real focus on efficiency. Why? They've got big numbers, right? So some of the kind of personalized care that we're used to, you don't get, okay? And that makes, in some ways, using AI and some of these other tools a little easier, privacy issues, data access. I think what I see in the Middle East is actually a real appetite for new shiny things, but I think on a management leader scale, I would say they're all, of course, it's very hierarchical, and there's this kind of younger generations coming up. They're very dynamic, but they can sometimes feel constrained by the other generation. So how do we address that? Well, we address it in two ways, and that is coming in and trying to upskill and work with middle managers in an organization. So we've had a big project in Saudi Arabia over the last year, working with the largest private healthcare group, really working with about 1/3 of their workforce. So coming in there, then we've got the upper group. Of course, they want the succession planning. They want the more moldable people. But we're also saying, well, let's bring in the other group, the people that have been here for a while. Let's do some thought leadership, some work with them as well. So I think there's where I see the big difference is actually around finance, how we finance our health systems. And again, it comes back to our values, right? Yeah. Some people ask me, can the United States have a universal health service? I would say no. Why? Because you've got people who are being over-medicated. They pay a lot of money for their health care. Then you have people down here who have none. When you average that and what the taxpayer would have to pay to kind of keep everybody happy, it's too high. So I think, yeah, there's of course differences, and what we try to do also when we come into situations like that is work with the client, understand, what are the differences, what would they like, and then how can we help them shift and solve what they see as kind of leadership and management issues.
Thank you. I have some large hospital CEOs that would probably like to talk with you.
Oh, well, I would love that.
Hi, lovely. As a clinician and entrepreneur, starting out, I think I just wanted to come into obviously your business model in starting the school, and how those nurses and people who are, I suppose, experts or wanting that zigzag career can afford, the input that you can bring them, because obviously the nurses do not come from a good salary, really.
Yeah, so if they're UK nurses, they get home fee rates that are actually quite reasonable. We also have added an apprenticeship. So we have a senior leader apprenticeship that actually pays pretty much a big chunk, 2/3 of your MBA. So they can go on and pay that up. And actually, we also offer a lot of scholarships, and we're working with different organizations to get more scholarships. So yes, that's a good challenge, but it's something I'm quite active at trying to address and build those and that's why working with industries, being much more agnostic, but saying, look, we're going to work with the health sector, that whole health ecosystem allows us to tap into different funds of money to help support our students.
Two things. It's comment actually, because a lot of what we do at UCL Global Health is based on my 30-year experience in the NHS. And when we go to Africa, the aim is to bridge the global non-global south divide. And I'm so excited with this presentation because in the last 5 years, we've been talking about changing the mindset about how health is delivered. As you rightly said, public is regulated, private is not. Private is overshadowing everything, so that we are addressing healthcare financing, public-private partnership, and most recently, when I've been to Geneva and then Cairo, what came out from the invitation, the roundtable that I was invited to, is how we can then train the workforce. We do upskilling as well in healthcare financing, because we had a summit in Ghana, and healthcare financing, EMA was, top of it, which was why we were invited. So my question is, when the students graduate, what do they then do? Where do they go?
So so that's a big question because we're just graduated our first class.
Oh, okay.
Okay, but we see them going in lots of areas, mainly into, of course, management type areas. So, but I just also back to this. So we do a lot of also short courses, and healthcare finance, of course, is an area that lots of people are interested in, or want to know more. And I just want to say, I'm not. I don't think we need everyone to go off and get degrees. And you might find that surprising because I'm coming from a university where I'm pushing degrees. I believe very much in, and this is where I put most of my energy in right now, is not in the degrees are fine and they'll recruit. It's in accessing this healthcare, workers. Because why? We have a whole generation or 2 generations of middle managers and senior leaders, and I've seen them in boardrooms. They don't understand a lot of this. They don't understand AI. They don't understand data analytics. And you get two groups. One group that just says yes to everything, doesn't know what they've agreed to, and then the other group that just blocks it all. So I think there's a real piece for us to be doing is just around bite-sized learning. It doesn't, and the other thing, so again, my experience is people are happy to just have a certificate. They don't need a degree. And so if you can put together something that's and the other thing, back even to nurses, they're working so hard. If I go, and this is why we did the apprenticeship, and we also have an executive online, because the first year we launched this in-person MBA, I was expecting more people from the NHS. And then I went to speak to some of the CEOs. I said, Nora, it's not even the price. We cannot have people out of clinic.
Yeah.
We cannot, and we don't even want to give them a study day.
Yeah.
You know.